and a warm welcome, Tobbie. It's been wonderful after a short break having you back with us. It's a special thank you. We have a warm bond going back many years, and we look forward to this bond continuing, especially as we have FIGO here in October next year, and I trust you'll be part of those academic presentations in FIGO in Cape Town 2025. Thanks, Tobbie, and over to you.
Thank you very much, Peter. Indeed, my relationship with Peter and association goes back a long, long time, many hours in theatre, and always fond memories of all of that. So today I've made my talk New Advances as the use of dydrogesterone in the treatment of endometriosis. So if the talk seems to be slightly biased, if I spend more times on the use of dydrogesterone, please understand. This is a new form of therapy, which many of you are not perhaps even heard that dydrogesterone has been approved for the use in endometriosis. So if we talk about the treatment of endometriosis, there's one Bible that we go back to, and that is the SRA Endometriosis Guideline Development Group's things. And any of you who want to read more about this, get the latest update. This was the 2022 version, and it was initially published in 2016. Now, and most of what I say is referenced on this SRA guideline. On the South African side, we have our own local society, the South African Society of Reproductive Gynecology, and they have also in 2016 published their views. I think Alan Alperstein was still at that stage the chairman of that specific guideline. And but basically, the South African version is based on the SRA version, and it refers to that. So, but it's not been recently updated. Now, just to get back to basics, what is endometriosis? So endometriosis is defined as the presence of endometrial-like tissue outside the uterus, which induces a chronic inflammatory reaction. But one should remember, just as osteoporosis, endometriosis is a chronic and an incurable disease in a significant number of women. They can experience either painful symptoms and/or infertility, or both, while others with endometriosis have no symptoms at all. The exact prevalence is unknown, but estimates range from about 2% to 10% in women of a reproductive age, and up to 50% in infertile women. So this is a fairly common condition, which I think anybody practicing gynecology needs to know a lot about. So what causes endometriosis? And most of you will relate this back to your days at medical school, the Sampson theory of retrograde menstruation. So what this basically means is that during menstruation, some of the endometrial cells will make their way through the tubes and through the fimbria lens, and then either get stuck to the ovaries, the structures around that, the lateral pelvic wall, or the pouch of Douglas. And but it is not as simple as that it's the pure presence of these endometrial cells there. The host also needs to have probably an altered immunity, probably a heightened leukocyte response around these, or something else that happens for these endometrial implants to take place. One of the reasons why this theory is still probably the most popular theory is the fact that the distribution of endometriosis pretty much mirrors the pathway, the migration of these cells from the tubes through the fimbriae. But there are other causes as well, of which I think coelomic metaplasia is probably the most important one, with lymphatic spread in immunologically and genetically susceptible individuals. So again, it doesn't happen in everyone, but some people will just provide the right environment for endometriosis to take place. So while the exact cause is uncertain, it is probably likely to be multifactorial, with also genetic factors, also possible epigenetic influences, that's influences on the baby in utero, and perhaps promoted through environmental exposure. Now, it is said that the rise of endometriosis, the prevalence is on the up, that it's up to 10% at least of women of reproductive age that suffer from endometriosis, which makes it 167 million women worldwide. Well, I'm not too sure whether it's actually an increase in the prevalence or whether we're not perhaps or more noted, or we are more on our guard to actually diagnose this condition. We are more aware of it, so we don't quite know why it is more prevalent. Now, most of you have learned that laparoscopy is a gold standard for the diagnosis of endometriosis, and not to start treatment until you have the diagnosis with the laparoscopy and also perhaps a histological confirmation. And this was indeed in 2014 in the ESRA guidelines. But that dictum has changed. And in the 2002 guidelines, it says that laparoscopy is no longer the diagnostic gold standard and is now only recommended in patients with negative imaging results and or where empirical treatment was unsuccessful or inappropriate. I would like to add probably as well the younger patient. So this is a great shift in that it is now allowed, if you suspect it's endometriosis, to give a clinical or a therapeutic trial before actually reverting to a surgical procedure. So once we've diagnosed the endometriosis, what would be the aim of our treatment? So we would look at reducing the size of the ectopic endometrial tissue. We would certainly like to address the pain to restore fertility, maybe without inhibiting ovulation, and also to avoid a generalized hypoestrogenic state with consequences such as vasomotor symptoms and bone loss. And it should be suitable for long-term use because, as I said in the beginning, this is generally an incurable disease, and as long as we treat, it's fine, but if we stop treatment, it may not be fine. And then as these patients want to fall pregnant, many of them, it should be safe in pregnancy in case we're there. So the treatment of endometriosis can be divided into surgical and medical therapy. And traditionally, surgery was indicated for infertility and the medical treatment for pain. But medical therapy, especially hormonal treatments, are increasingly considered as first-line therapy for both indications, as it avoids potential surgical complications and it preserves ovarian function. Medical therapy can also be used as cell therapy or as adjuvant therapy pre or post-surgical. And in addition to the surgical medical therapy, we also have assisted reproductive techniques that are often required for fertility in this group of patients. So let's just, for one moment, go back to the physiology and we see what happens at the level of the endometrium, because here are some very important concepts. So the first concept is that in the first 14 days of the cycle, under the influence of FSH and the subsequent estrogen, we get endometrial proliferation where it becomes thicker. But after ovulation, we also have progesterone secretion, and that causes secretory transformation. So put in a simple view, this is the phase where you step on the petrol, and this is the phase where some brakes are added to the equilibrium. And that protects the endometrium from growing while they're out of control. Now, we should also remember that estrogen, or that endometriosis, is an estrogen-dependent disorder. So endometriotic tissue has a higher local availability of estradiol, and that may be explained by higher aromatase enzyme expression. That means that it will be easier for estrone to be converted to active 17-beta estradiol, so from E2, E1 to E2, or otherwise impaired conversion of the very potent E2 to less potent E1. So there's probably something on a local level that favors estrogen under the circumstances. Then, secondly, in a normal endometrium, the progesterone, which is secreted from the phase of ovulation, will facilitate the transition of proliferative endometrium to a secretory endometrium. But in endometriotic, this effect is blocked by an increased local endogenous E2, resulting in incomplete endometrial transition. And this disables a critical protective mechanism against estrogen-induced growth of endometrial tissue. So it all boils down to we have too much estrogen for whatever reason, and our progesterone may be there, but it's not working as well in keeping that extra petrol under control. So if we're going to treat endometriosis, we can do it at three fronts. We can inhibit the estrogen activity by whatever way, and we'll discuss that now, or we can amplify the effect of the progesterone on the endometrium, or we can use anti-inflammatories. As we said from the beginning, this is a disease which is also driven by the inflammatory response. So if we have a look at the ESRE guidelines, and this is the latest one, the 2022 ones, we just capture the headlines, which says that endometriosis is impossible to cure, but you can arrest the development of the disease. And new strategy favors conservative medical treatment. So the first line medications, according to ESRE, will be the pure progestogens, and we'll discuss them just now, or the non-steroidal anti-inflammatory drugs and analgesics, and it may be the combined oral contraceptive, but I don't actually agree with them there. We'll talk about that. So why is medical therapy an essential component of the treatment? Well, even if you do perfect surgery, it is bound to recur if you do not add also medical therapy to it. So the best strategy makes use of all options and should always include medication as well as surgery. And previously, this was a problem in terms of the patient that wanted to fall pregnant, that you could operate her, but then the progestogens that was used was not allowed to be used in pregnancy, so you couldn't give it. But now you'll see with dufaston or dydrogesterone, that is safe to use it after surgery for infertility, as it is safe in pregnancy. Okay, so if we then have to recap the hormonal treatment of endometriosis, let's first take the right-hand side. How can we inhibit the estrogen? We can do it on a central level with the GnRH analogs. Remember these drugs, they downregulate the GnRH receptors so that you become postmenopausal, or by direct GnRH antagonists. Now, we haven't got the GnRH antagonists on the market yet, but I mean, it's been available in the United States for about 3-4 years now. Danazol also has an anti-estrogenic effect, but it's really not being used anymore. Sorry, SERM is a theoretical drug. I'm just putting it there, also a selective estrogen receptor modulator. And then aromatase inhibitors, I'm not going to talk a lot about that, but if you're dealing with post-menopausal endometriosis, it's normally not responsive to the normal therapies, and the aromatase inhibitors seem to play a role there.
Sorry, Tobbie.
Yep.
Tobbie, are you going to be saying something about postmenopausal endometriosis later?
I will say something about that, and that's where the aromatase inhibitors will also come in. If I take it out of the deck, I can't remember what I did last night, but I'll I will address it specifically.
Okay, thanks, Tobbie.
Okay, so we said you can either go against the estrogen or you can go pro the progestogen. So what we have on that side will be the oral oral contraceptive. Sorry, the first one would be the whole range of progestins, which we are going to discuss just now. You can have the intrauterine device that secretes a levonorgestrel. You can use the depot injection, Depo-Provera injection, that's medroxyprogesterone acetate. And then just for the ones of you think a little bit further, the selective progesterone receptor modulators, we did a little bit of work on that. It actually also works, but it's not available for that reason on a commercial level. Okay, so what about progesterone that we're going to use? How are the effects mediated? And that's via an intracellular progesterone receptor. And this is progesterone receptor A and B. Remember, this is not alpha and beta like in estrogen. This is an A and a B. And progesterone resistance is one of the possible causes of endometriosis. And this is characterized by lower PRA and absent PRB compared to normal endometrium. So the progestins, the antiprogestin and selective progesterone receptor modulators are drugs that reduce progesterone resistance by direct action on the progesterone receptors. So I'll leave out the other ones and just say the progestins, which we're going to discuss now, they have a direct effect on the progesterone receptor to enhance the effect of your progesterone that you use. And then progesterone therapy also have a marked anti-inflammatory effect, which in part explains the analgesic effect that it can have. So if we have a look at our progestogens, remember progestogen is the family name for any drug that stimulates the progesterone receptor. The only 100% natural drug would be progesterone, or P4, which is produced by the corpus luteum, which can also be manufactured from a plant origin. The drug that is the closest to progesterone, as you saw in the first video, is the retroprogesterone dihydrogesterone. So this is the closest that we have, but it's still not a naturally occurring hormone. It is actually comes from the same plant origin where they get the progesterone from, but by the mirror effect, it is bent, and it actually then has a greater effect on the progesterone receptor than progesterone itself, with fewer side effects. The rest of our progestogens can be your spirolactone derivatives, drospirenone, which is not used in terms of our discussion of endometriosis, or you can have the progesterone derivatives or the testosterone derivatives that we have here. Now, from the progesterone derivatives, we have the old medroxyprogesterone acetate, MPA, and in terms of endometriosis, this is what is used in Depo-Provera. Then from the 19-nortestosterone side, we have levonorgestrel, and that is the drug that is on the Mirena intrauterine contraceptive device. And then we have Dynogest, which is also, and we will discuss it now, and none of the gonanes are basically used. So we have from the progesterone side, medroxyprogesterone acetate, and then we have the levonorgestrel and Dynogest from the 19-testosterone derivatives, and we have dihydrogesterone, which is the closest to natural progesterone. Now, so the star of the evening, which is now in South Africa, registered for the use in endometriosis, is dihydrogesterone, which, as you heard from Henny's video, was actually already present in the 1960s. That's when I went to school. Now, it is a retroprogesterone, so it's a stereoisomer of progesterone with an additional double bond between the carbons 6 and 7. It's shaped by light, as we said, from the same natural source as progesterone, and it binds highly selective to the progesterone receptor, resulting in minimal side effect. It is unique, though, in the sense that it has no estrogenic, androgenic, or glucocorticoid effects. And your normal, what can happen to a progestin is that it can be either estrogenic or anti-estrogenic, androgenic or anti-androgenic, or a glucocorticoid, or unlike that. But the main thing is that it does not inhibit ovulation at the normal dosage used in endometriosis. So that is definitely an advantage in your infertility group of patients. But in the patients just for pain, it can also be used, and I'll address that a little bit later on. So the anti-androgenic potential of dydrogesterone is less pronounced compared to progesterone. So the dosage is 20 or 30 milligrams. Remember from that video, it comes in a 10 milligram pill per month, and it can be given either continuously, so that's a daily dosage, such as we use with Dynagest, or it can be cyclical between day 5 and 25th day of the menstrual cycle. So that's an advantage in that the patient doesn't necessarily have to be amenorrheic if she doesn't want to be. So it alleviates endometriosis-associated pain and the regression of the lesions. I'll show you the proof just now. And it's been registered for the use in endometriosis in European countries for many, many years, and it's widely used there for that reason. And another place where dydrogesterone, it can be used in combination with estradiol valerate as add-back therapy in patients on GnRH analog therapy. In other words, the patients that you've made them menopausal, but you want to protect the bones, you want to relieve the hot flashes, then you can use the dydrogesterone as add-back therapy.
So, Toby, can you just go back to that slide again, please? The first bullet over there, it's 2 tablets daily by mouth, either continuously or cyclic. Which do you prefer?
Okay, we've all become accustomed to giving it in a continuous way. But if the patient prefers to menstruate, you can give it cyclical. I prefer the continuous once a day.
Okay.
It's just much easier. If you have a look, and we'll, there's one big study, Orchideo study, Orchid study, which I'll show you, which showed that there was no difference between on the pain effect, whether you used it continuous or whether you used it in the cyclical way.
Okay, thank you.
Okay, so again, we are repeating this now, that it does not suppress ovulation, and that is if you stick to 20 to 30 milligram daily. And it can be prescribed to women are planning to become pregnant, but it also enhances the pregnancy success rate in patients with endometriosis. So it is effective at reducing the risk of sporadic and recurrent pregnancy loss. And if you had a look at the video that Henny showed us, it is also registered for that reason in patients with recurrent pregnancy loss. And this is significant in the treatment of endometriosis infertility, as endometriosis patients that fall pregnant have an increased risk of miscarriage. And Dynagest, as we know, is contraindicated during pregnancy. So just bear that in mind. So
would you use the same dose then if they fall pregnant? Just keep going at 2 daily.
You can continue with your dose exactly as you are, as long as you stick to less than 30 milligrams daily.
Okay.
So what proof do we have? Now, I'm not going to go into the details of the study. That'll keep us busy the whole evening. So this is just one to show that there's a reduction in endometriotic lesions. And this is actually at the low dosage, only 10 milligrams. And it was in a cyclical way, day 5 to 15, and 20 milligrams then from 16. So this was in days before they decided on the sample. But you can see that laparoscopic examination found elimination of endometriosis in 15 out of 20, that's 75% of cases, and improvement in endometriosis in another 15%. So, I mean, it's not large, big studies, But this is one of the classic studies that was used for registration, the Kaiser study. And this is the so-called, this is another study by Kaiser, where they showed this very nice regression of reductions in symptoms of pain with endometriosis, again using the cyclical dosage. And this is again another study, the so-called Trivedi study, where you can clearly see that there is a big improvement of symptoms in patients with endometriosis. Anybody wants to go back to these studies, I will later. And this is the latest study. You can see all those studies were actually done quite a few years ago, which led to the registration in Europe. In South Africa, it was never declined. They just never applied for registration. So in this one, which was published in Fertility and Sterility, any of you that know about that, that's the Bible of infertility. So if you get a publication there, you can make sure that it's been properly peer-reviewed, and it decreases the score of intensity of chronic pelvic pain, and that is on both the cyclic and the once-a-day study. It made no difference to the outcome. So how does it bring about the effect on the alleviation of pain? Well, firstly, it's obviously, as the lesions get smaller, there's less bleeding and less inflammation, but there is a direct anti-inflammatory response. I'm not going to go into any of this, but for you just to know that there's also a direct anti-inflammatory response, which probably contributes a lot to the pain effect. This is just, again, to remind that you are allowed to use this in pregnancy. I'm not going to go into that. Now, this is just to show a study that digesterone therapy after laparoscopy. So in these patients had symptoms of endometriosis. They just underwent a simple laparoscopic examination to actually prove that they have endometriosis, and then they either got digesterone or not, and that there was a higher rate of pregnancy in the patients on digesterone. Well, in this rather smallish study, 50% of the patients fell pregnant versus 26%. So for all the aspects that we want, there is in fact studies to support that, though it's not, except for Orchideo study, not very recent and not large in numbers. And if we compare that to the literature that we have available on Dynogest, it definitely is the Dynogest. There's a lot of recent publications that's been done. Now, it is also important to know that it has no effect on the risk of thrombosis. And that is important if you have to compare it versus the use of the oral contraceptive pill, which in any case, I don't actually advise on using for. In terms of safety and tolerability, well, this is a progestogen, and all progestogens have a side effect profile, which you see here. But I mean, it's not any worse than any of the other progestogens. And lots of these side effects can be addressed by the patient taking it in the evening, and when she actually will enjoy the sleep that it induces. But so if you just have a look at the top line here, we see that the incidence of the side effects are actually very small, uncommon, and rare. But there's no drug that hasn't got side effects. And in terms of what we're dealing with, the progestins, this is par for course. Dynogest, you all know this very well. This is at the moment probably by far the most common medical therapy used for the treatment of endometriosis. So this is a C10 nortestosterone derivative that binds to the progesterone receptor. And when taken continuously, remember Dynogest, you must take it continuously. It inhibits systemic gonadotrophin secretion and has local anti-proliferative and anti-inflammatory effects. So the effects basically is the same, but the main point here is that at the normal dosages taken, you will get subcentral suppression, and the patient can have bone effects and other systemic effects where that does not happen with the dydrogesterone. This is normally 2 milligrams daily per mouth, And this is probably the easier one to take, because the other one would be 2 tablets or 3 tablets per day. So there's lots of studies showing that it's effective in controlling endometriosis-related pain, such as dysmenorrhea, premenstrual pain, and also in deep infiltrating endometriosis pain. It's been shown to be as effective as a GnRH agonist, but with a better side effect profile. So you don't get the absolute postmenopausal state as you do get with the GnRH agonist, but there is an amount of central suppression. The main side effects of digest will be bleeding irregularities. And Peter, this is if a patient has bleeding irregularities on a continuous daily, then you switch the patient if she's on dinogestrone to the cyclic one, and that normally clears it up. Whereas with your Dynagest, you can't do that. The only studies we have are on daily dosages.
Okay, Toby, just on that, I've just had some questions. There's a lot of questions here. Some people say, is Dynagest that is marketed by Bayer as Vizan? And that's correct, yes?
Yes, absolutely.
Okay,
Sorry.
thank you. And one last question, just to get rid of this dose thing, people they're still slightly confused. Which dose you can use 1, 2, or 3 tablets? That's 10, 20, or 30 milligrams daily. Which do you start? Could you just tell us how you begin and what dose do you maintain?
I think that the best dose to use is 20 milligrams.
2, okay.
2 tablets, and I give it daily, but you can give it from 5 to 25. And if you do not have joy, you can go up to 30.
Okay, thank you.
3 tablets. Okay, so this is basically just a comparison between the dydrogesterone and the Dynagest. Okay, so let's make it more clearly for you. Dufaston versus the Dynagest. Now, the Vizan. So both are first line for endometriosis. Both reduces pain. Both you can use continuously every day, but you can only use your dydrogesterone or Dufaston in a cyclical regime as well. You cannot do that with your Vizan. It has to be every day. And this is effective in cases of breakthrough bleeding. And then your Dufaston does not suppress ovulation, which happens in the other one. This is approved for pre-pregnancy care. That one is not. It is approved for use during pregnancy on the Dufaston side and not on the other side. And it does not cause clinical hypoestrogenism. And for instance, there's no bone loss. You can find bone loss on Vizan, especially in the first couple of months and especially in the younger patient. Okay, so now we're just going to quickly go over the other drugs that are available. Peter, just for I think at 45 minutes, we got to stop for questions. But your pure anti-estrogens, your GnRH agonists, many of them on the market, mostly as a depot injection, and they work very well. And they work by suppressing centrally. The GnRH releasing hormones are blocked, but it makes the patient hypoestrogenic, so it gives the patient hot flushes. It has negative bone effects, and you normally need to give estrogen add-back therapy in low-dose estrogen plus dydrogesterone. Your antagonist, because it's not available here, I'm not going to discuss it, but the elagolix, we did lots of studies on elagolix. It works well, but boy, these patients really get menopausal symptoms. More of importance, what about the combined oral contraceptive? So in spite of it being commonly used for that, there remains a lack of solid clinical trial evidence supporting the use of it, and it's all used off-label to alleviate symptoms of endometriosis such as pain. But I question the rationale of this, because you're not actually giving estrogen to a condition that is driven by estrogen, and I don't use it for that reason at all. So there's also a study that has drawn a possible association between the past use of combined oral contraceptives for severe primary dysmenorrhea and surgical confirmation of deep infiltrating endometriosis. But I wouldn't accept that as the Bible. Danazol, not on the market anymore, but it was basically just an anti-estrogen. What about our levonorgestrel containing intrauterine contraceptive device? Yes, for the patient who does not want to fall pregnant, and especially the one who's had pelvic surgery, this is a good alternative for local release of the levonorgestrel, and it is commonly used for that. But obviously, patient can not fall pregnant. So if we then just go quickly with the indications for treatment, and we have then in this line here, we have an anti-estrogen, and so that would be the GnRH agonist. Here we have Dynagest, and here we have digesterone surgery, and then assisted reproductive techniques. So we see that, and I'm going to just skip the lines here. Digesterone you can use for any of the indications. You can use it for pain, you can use it for infertility, pre-op and post-op. Whereas with your Dynagest, or the Visan, you cannot use it for infertility, and it is not used often pre-operatively, and it can't be used post-operatively, except if the patient doesn't want to fall pregnant. Surgery is first line in infertility and second line in pain, and our assisted reproductive techniques are second line, but very often these patients will need a form of assisted reproductive techniques to fall pregnant. Now, Peter, I'm just going to a few words about postmenopausal endometriosis. Yes, it can occur postmenopausally as well. So our first scenario is the patient who previously had been treated for endometriosis and is now postmenopausal with symptoms. Can we give her menopausal hormone therapy? Yes, you can, but very often these patients has had hysterectomy. Hysterectomy is previously often used as a treatment, although it really makes no sense. So if the patient has a hysterectomy, we normally would give that patient unopposed estrogen. But in a patient with a history of endometriosis, you need to give combined therapy, and there Dufaston again is a very good form of, and you can give it in the form of Femostin, for instance. Now, what do we do if a patient, and how does a patient present with endometriosis postmenopausally? So there are two things that can happen. One is we can get the reactivation of old endometriosis or previous endometriosis, or two, we can have malignant transformation of the endometriosis to an endometrioid type carcinoma. And both of them would probably present with pain and sometimes with postmenopausal bleeding. Now, obviously, the diagnosis of the malignant transformation can only be made by a good biopsy. So it's important in that patient to take the biopsy so that and if then indeed it is an endometrioid type carcinoma, our oncology friends will know exactly how to deal with that. It will be surgical with follow-up hormonal, anti-hormonal therapy. In terms of the pain, if it is not responsive to the surgery that we've done, that's where the aromatase inhibitors come into play. There's been a few studies on that, which have actually shown a big improvement in pain. So remember what the aromatase inhibitors does. Aromatase inhibitors are the drugs most commonly used in the treatment of estrogen receptor positive breast cancer. So it blocks the aromatase reaction or aromatization in the postmenopausal patient of estrone coming from the adrenal glands to active 17-beta estradiol. So there's good evidence, or there's a good proof of concept that it should work, and there is some limited evidence that it actually does work. Peter, I think that in conclusion, there's consensus that progesterones, including digesterone and Dynagest, can be regarded as first-line therapy for endometriosis. It has previously not been approved in South Africa, but it's now approved. It's been shown to effectively diminish the size of endometriotic implants, relieve pain, be effective for the enhancement of endometriosis-related infertility. It does not cause hypoestrogenism. It does not inhibit ovulation and may be used in pregnancy. So when discussing this with some of my friends who deal a lot, but more surgically with endometriosis, their concern was that, well, this can only be used in the patient that wants to fall pregnant. If the patient doesn't want to fall pregnant, you should treat them with Dynagest. But that's not true, because Dynagest does not always completely suppress ovulation, and patients can fall pregnant on Dynagest. If they do fall pregnant on Dynagest, we have a problem because we're not quite sure what the effect on the unborn fetus would be of that. So any patient taking any form of progesterone therapy who does not want to fall pregnant needs to also use barrier contraception. And in all the endometriosis studies that I've been involved in, that has been the protocol standard, that patients should use condoms as long as they're on these drugs. You just get the one or two that can fall pregnant on Dynagest, and with devastating consequences. In the trials that we did, the protocol actually prescribed that the pregnancy needs to be terminated. Okay, Peter, I'm here for the questions.
Tobbie, it's been wonderful, absolutely wonderful presentation. We've heard lots of new things, not one or two facts, but dozens of new facts over here. I'd like to thank you and say this is, ladies and gentlemen, you heard it here on the Pelvic Floor Foundation presentation by Dr. Tobbie de Villiers first. There are lots of questions. I just want to run through, if I may, the questions. Here they go. Can dydrogesterone be used concurrently with the Mirena in patients who received the Mirena but do not have sufficient symptom control? Douglas Whitston's asked that. What is your response, Tobbie?
Okay, well, I don't think it's ever a good idea to use two drugs of the same class together because we just really don't know what's going to happen. But if the Mirena we know is absorbed very, very little, so I don't think that there is a lot of danger involved in that. But if it's for the contraceptive effect, I would still say Dynagest or your Famostin, not Famostin, your Dufaston with barrier contraception rather.
Okay, and similar one, Sheena Matthew says, for patients with endometriosis who don't want to conceive while on treatment, do they need to take additional contraception, and what would be recommended? Yes, you mentioned that.
Okay. Yeah, absolutely, but barrier contraception.
Okay. Another one over here, endometriosis is caused by, in part, retrograde menstruation, but the cause is multifactorial. Do women who don't menstruate still get endometriosis?
Yeah, it can happen, and that's where the coelomic metaplasia comes into play. So coelomic metaplasia, just to put it in maybe in more understandable or appetizing format, would be if you just consider that the pelvic structures that are involved comes from the same embryonic mesothelium, but they develop into different forms and different organs. So if there's a problem with the development of tissue that's outside, they can develop into what should have been inside the uterus. So that is a problem, and that can probably be the multifactorial one, that it could have been something that happened intrauterine, even the epigenetic factors that caused the metaplasia to occur in that way.
Okay. Leonel says, available GnRH agonists in South Africa, by what market name do they go, Tobbie?
Okay, so you have various ones. The one that she will probably, is it he or she?
Leonel.
Okay,
it's our friend Leonel.
Oh, Leon. Okay.
He or she. Leonel won't like he or she. Leon, him, Nell. Yeah, him.
There's a South African a singer by the name of Lionel, which is a she.
No. His son is the police car man. This is the father.
Okay. Now, but that's Venter. That's not Nell.
Oh, Well, this is Leon Nell.
Okay. Um, so now we can get on. So what was the question again, Peter?
Leon Nell says, what is the trade name
Oh,
of
the
the
trade name.
available
Sorry.
GnRH agonists in South Africa? Its market name.
Okay. The market name, best known one is Zoladex. Okay. Zoladex is an injection that's given, and it normally lasts for about 3 months. Then you have to repeat the depot injection, but you can also take it as Lucrin, which is another trade. And those are the two most common trade names. But just
Okay,
remember,
next.
if you
Sorry.
use these drugs, you induce the patient in a premature menopause. So it's a
Yeah.
total anti-estrogen effect with all the other stuff. This is very commonly used by our oncology friends with patients with estrogen receptor positive breast cancer, and if they are in the reproductive age group, so you can give it, and the effect is the same as if you would have given the patient an oophorectomy.
Okay. The next question, why is Depo-Provera not more widely used in this country?
Okay, so Depo-Provera contains medroxyprogesterone acetate. Now, if we go back to the WHI study in menopausal medicine, in menopausal hormone therapy, that study, the WHI was with conjugated equine estrogen and medroxyprogesterone acetate. And the results were very bad for the medroxyprogesterone acetate group. Um, Actually, in virtually all the different categories, the estrogen alone was good. But the moment that you added the progesterone acetate, there was a deleterious effect. And it is often blamed as the fact why the breast results, especially, were not good in the WHI study. Now, the reason why MPA is not a good drug is that it has a lot of other metabolic side effects. So it's like a shotgun shooting at the progesterone receptor. So it has lots of side effects from that. So for that reason, it is not used by purists. But just must now put my bone hat on. In patients that use it as contraception in our state hospitals mostly, these patients, in these patients, it has a very deleterious effect on bone. And we from the NAFSA, we don't advise on using Depo-Provera even for contraception because of the adverse effect on bone. Just remember, it initially does not suppress ovulation, but in the end, it suppresses ovulation certainly, and it brings down the level of estrogen, and that's why it's probably good have good results in endometriosis, but I do not recommend using. We got better drugs.
Okay. Thank you. There's another comment from Leonel, but I cannot read it out because it's disgusting. Then there is, let me ask a question, just going off piece about Depo-Provera. It's widely used in our state sector for contraception, as you know, from women that are young and then women that are even older. Why is it still available if it is not a good drug?
Okay, it is not available in many overseas countries for that reason, and I do believe from my endocrine friends that deal with that in the state hospitals that they rather give the implant. Sorry, Peter, what's the
It's
implant's
called
name now again?
Implanon.
Yeah, that's right. Let rather give Implanon because it hasn't got that effect on the bone. But I do not know the effect of the Implanon on endometriosis. It probably will be okay, but I don't know. So yes, in the state hospitals also they are moving away from it and rather going through the
Okay.
implant.
One of the biggest problems with the Implanon we see is abnormal bleeding. And Depo-Provera, for all its faults, you do treat that not with quite easily. But Implanon does have the big problem of abnormal bleeding. Here's another question from Zinath Waja. in a patient not wanting to pregnant, would the Mirena be sufficient to treat endometriosis? In other words, what is the effect of Mirena on endometriosis?
Okay, it's a very limited effect, but it is good enough to use it post-surgically. But as a primary one, you can try it, but it's unlikely to have any great effect on pain, except if the pain is mostly associated with menstruation. So use a little bit of common sense there, but yes, it is included amongst the drugs that can be used for endometriosis.
Okay. On that question, does this is slightly off-piste again, does the Mirena cause ovarian cysts that can be confused with endometriomas of the ovary?
That does Mirena. What was the question?
Yeah, does Mirena cause ovarian cysts which can be confused with endometriomas? That's the question.
Okay. Yes and no. We all know the so-called Mirena cysts, and that is a direct effect of the progesterone, the levonorgestrel, on the ovary that causes it. But you will also know that those cysts are simple cysts, and they are hardly ever just one cyst. So it's multiple smallish, simple cysts, whereas your endometriotic cysts are much different, and the endometriotic cyst normally even gives you a solid appearance because of the blood inside the endometrioma. So I don't think that it's very easy to mingle the two. The Mirena cysts are all just simple cysts.
Okay, thanks, Tobbie. One last question over here. It's again slightly off piste. FIGO Cape Town 2025. When is it? That's October 2025. It's here in Cape Town at the CTICC, and I advise everybody to book as soon as possible. You can go onto the FIGO website. You can see we're already organizing it. I'm on the organizing committee. I organized FIGO here in 2009. Did you come to that, Tobbie? 2009 FIGO? You were there?
Yeah. I was with you on that committee.
That's what I remember. That's what I remember.
I still remember that you wanted to get tame leopards to walk around with men in small bathing suits at the opening ceremony, and Zefni nearly caught a fit.
Yeah, that wasn't tame leopards. It was Femi Laragon having a hyena on a leash, and
whatever.
Yeah, Zefni wasn't appreciative of my story. So, ladies and gentlemen, we've now got to the end of our webinar at 6 o'clock. We've had an absolutely wonderful academic exposition here by Tobbie de Villiers. He, him, as now says there, I see. And it's been absolutely wonderful. The questions have been good. The sponsors have been marvelous. And they even gave me a packet of the sponsor's product. I don't know who else has got this, but thanks to Abbott, who's given me a packet of the sponsor's product. It's wonderful. I'm certainly going to be using it. And a final thanks to Abbott, and to advise you that next week, our next webinar is the 25th of April. It's overcoming barriers to influenza and the role of the gynecologist in advocating for vaccination. And the speaker then is Amy Wise, and the sponsor is Sanofi. So Tobbie de Villiers, he, him, thank you so much for being with us this afternoon. It's been a great pleasure and an honor, in fact, because he has a person with great authority. He speaks with great, he brings a background of wonderful knowledge. And on behalf of all of us, there's been many hundreds of people logged on this afternoon. It shows how popular your talks on hormones, especially progesterone, menopause, and endometriosis have become. Tobbie, thank you on behalf of all of us over here. I'm sorry Steve couldn't be here, but in 2 weeks' time he'll be back. And then we'll be having our talk on vaccination by Amy Wise. Ladies and gentlemen, safe home. And once again, thanks very much. A special thanks to those that have logged on and been with us this afternoon. Thank you, Tobbie, and good night.
My pleasure, Peter. Always nice seeing you.